Assalamualaikum and a very good morning to Sir Hamdan. My name is Alicia Effendi and I am currently taking Bachelor in Cardiovascular Technology. Today I will be presenting on my case study for the subject electrocardiography (ECG). My topic for today is polymorphic ventricular tachycardia and cardiac arrest from abiraterone-induced hypokalemia. Before we start, I would like to go through our table of contents for today, with the first one being the case study article, the second, introduction, patient chief complaint and information, medical and surgical history, ECG findings with explanation, management and treatment, discussion, SWOT analysis, conclusion, and lastly, the references. Firstly, we have the case study article, which I have included the link to the case study and also my QR code for my assignment document. Now, let's start with the introduction. Polymorphic ventricular tachycardia (PMVT) is a life-threatening arrhythmia characterized by a rapid, irregular heartbeat with wide and variable QRS complexes. This arrhythmia can result in sudden cardiac arrest if not promptly addressed. While urgent defibrillation and adherence to advanced cardiac life support (ACLS) protocols are essential for stabilizing this patient, identifying and managing the underlying cause is critical to preventing recurrent episodes and long-term complications. The causes of PMVT can be characterized into reversible and irreversible factors, such as coronary ischemia, electrolyte imbalances, and genetic predispositions. Secondary causes, including medication-induced electrolyte disturbances, also play a significant role in the onset of PMVT. In some cases, the treatment designed for one underlying cause may exacerbate another, highlighting the importance of precise diagnosis and also treatment. Abiraterone, an androgen synthesis antagonist commonly used in the treatment of metastatic prostate cancer, is known to affect adrenal steroid biosynthesis. While it has proven effective in prolonging survival for patients with castration-resistant prostate cancer, one of its less common but serious side effects is the induction of hypokalemia and other electrolyte disturbances. These complications can lead to a significant cardiac arrhythmias, including PMVT. In this case, it is presented that a 78-year-old male patient developed polymorphic ventricular tachycardia secondary to severe hypokalemia induced by abiraterone therapy, illustrating the critical need for careful monitoring and management of electrolyte levels in patients undergoing such treatment. Now, let's move on to the patient chief complaint. In this case, it is a 70-year-old African American male presented to the emergency department with dizziness. So the chief complaint here is dizziness. For the case presentation, the patient, while driving himself to the ED, experienced a syncopal episode in the parking lot. He spontaneously recovered and managed to walk to the hospital. During the initial evaluation at the ED, the patient experienced another episode of loss of consciousness and was found to be in polymorphic ventricular tachycardia. For the initial intervention, CPR was promptly initiated upon the second loss of consciousness. Intravenous magnesium and amiodarone were administered. The patient required 4 rounds of defibrillation before achieving return of spontaneous circulation, ROSC. After ROSC, the patient exhibited bradycardia with a heart rate of 30 beats per minute and experienced repeated episodes of non-sustained polymorphic ventricular tachycardia. The patient's medical history includes atrial flutter, hypertension, and prostate cancer. His atrial flutter was managed with rate control, and he was on apixaban for stroke prevention due to a CHA2DS2 VASC score of 3. Prostate cancer, diagnosed 12 years ago with metastasis to the cervical spine, left hip, ankle, and toes, had been treated with multiple therapies, including triptorelin pamoate, diethylstilbestrol, enzalutamide, sipuleucel T, and abiraterone with prednisone. However, he stopped taking prednisone several months ago when his prescription ran out. His hypertension was initially uncontrolled, leading to hospitalization for hypertensive urgency a year ago. Subsequently, his blood pressure was stabilized with amlodipine and losartan. But due to lower extremity edema, amlodipine was replaced with chlorthalidone about 9 months before his current presentation. Next is the ECG finding. An ECG showed a regular accelerated junctional rhythm with premature ventricular contractions and a right bundle branch block. The QT and QTC intervals were prolonged at 492 milliseconds and 568 milliseconds respectively. Further investigations were performed. A bedside transthoracic echocardiogram revealed a mildly reduced left ventricular ejection fraction of 48%, with no wall motion abnormalities or significant valvular issues. Following ROSC, lab tests indicated persistent hypokalemia despite daily potassium supplementation of 100 to 300 MEq. Further evaluation revealed low renin activity at 0.21 ng per ml per hour, while the normal should be 0.25 to 5.82 ng per ml per hour. An undetectable plasma aldosterone level and ACTH level slightly elevated at 54 pg per ml, while the normal should be within 6 to 50 pg per ml, and a morning cortisol level of 12.5 Ug/dl. At the time of this testing, the patient's potassium level remained critically low at 2.7 MEq per liter. A 24-hour urine potassium collection was within normal limits at 112 mmol per 24 hours, because the normal is 25 to 125 mmol per 24 hours. Next is management and treatment, as laboratory evaluation revealed that there is no other clear cause for the hypokalemia. It was determined that the electrolyte abnormalities were likely due to the use of abiraterone without glucocorticoid, leading to excess mineralocorticoid activity. The patient was started on prednisone 20 mg daily, but this led to only minimal improvement in potassium levels, reducing the daily potassium requirement from 160 to 120 milliequivalents. Eplerenone 25 mg daily was then introduced, further decreasing the potassium requirement to 80 milliequivalent daily. Despite normalization of serum potassium, the patient continued to experience persistent bradycardia with heart rates in the 50s. During hospitalization, various heart rhythms were observed, including Mobitz 1, ectopic atrial beats, atrial flutter, and fibrillation, intermittent sinus arrest, and persistent bifascicular block with right bundle branch block and left anterior fascicular block. Given these findings, the decision was made to implant a permanent pacemaker before discharge. While the possibility of an implantable cardioverter defibrillator (ICD) was discussed, it was ultimately deemed unnecessary. The initial ventricular tachycardia (VT) was attributed to severe hypokalemia, which was considered reversible with adjustments to the patient's treatment regimen. Therefore, the risk of recurrent VT was deemed unlikely. After correcting the hypokalemia, no further episodes of polymorphic ventricular tachycardia occurred. The patient's QT and QTC intervals improved to 466 milliseconds and 477 milliseconds respectively on ECG prior to discharge while being ventricular paced. Given the absence of anginal symptoms or ECG changes suggestive of ischemia, and with a more likely cause for his initial presentation, coronary evaluation was not performed. For follow-up, abiraterone was discontinued and the patient was gradually weaned off prednisone. He was discharged on lisinopril, eplerenone, and potassium chloride 40 milliequivalent twice daily. 2 weeks after discharge, the potassium dose was reduced to 40 milliequivalent once daily, and it was discontinued entirely 4 weeks after discharge, at which time his serum potassium was 4.9 milliequivalent per liter. Now let's move on to the discussion. The patient in this case experienced polymorphic ventricular tachycardia following an episode of hypokalemia. which was most likely induced by the use of abiraterone without glucocorticoid therapy. Abiraterone, a selective CYP17 inhibitor, reduces cortisol production by inhibiting 17A hydroxylase and 1720-lase, leading to an increase in ACTH. This in turn stimulates the overproduction of mineral corticoids like 11-deoxycorticosterone and corticosterone, causing a reduction in aldosterone levels. The resulting electrolyte imbalance, particularly hypokalemia, is a well-documented side effect of abiraterone use without prednisone co-administration. In this patient, despite adequate potassium supplementation, he continued to experience persistent hypokalemia, which significantly contributed to the development of VT. Hypokalemia plays a critical role in triggering arrhythmias, as it impairs repolarization, prolongs the QT interval, and increases the risk of both polymorphic VT and other potentially fatal arrhythmias like torsades de pointes. Additionally, the patient's electrolyte disturbances were exacerbated by the use of chlorthalidone, which may have contributed further to potassium wasting. The episode of polymorphic VT, requiring 4 defibrillation attempts and multiple interventions, is a clear illustration of how severe electrolyte disturbances can precipitate life-threatening arrhythmias. Moreover, abiraterone's effect on the cardiac conduction system cannot be overlooked. The drug is associated with an increased risk of atrial and ventricular arrhythmias, including VT. In this patient, although a history of atrial flutter existed prior to abiraterone therapy, the onset of VT and the need for multiple defibrillation attempts suggest a direct link between the severe hypokalemia induced by the drug and the subsequent arrhythmic event. This highlights the critical need for careful monitoring of potassium levels and the appropriate use of glucocorticoids when managing patients on abiraterone therapy. The patient's condition was managed with the introduction of prednisone and eplerenone, the latter of which was chosen over spironolactone due to its more favorable profile in patients receiving androgen deprivation therapy. Eplerenone helped to control the mineral corticoid excess, reducing the patient's potassium requirement. After correction of his hypokalemia, the patient did not experience further episodes of VT, and his ECG showed significant improvement in the QT and QTC interval, further supporting the idea that the initial VT was secondary to electrolyte imbalance caused by abiraterone therapy. This case emphasizes the importance of managing and monitoring the potential electrolyte disturbances and arrhythmias associated with oncologic treatments like abiraterone, especially in the absence of appropriate steroid supplementation. Now let's talk about the SWOT analysis, with the first one being strengths. For the strengths, the first one would be timely medical intervention, because the patient was quickly evaluated and treated after presenting with dizziness and syncope episode. This led to the early identification of polymorphic ventricular tachycardia and allowed for prompt resuscitation, including the use of magnesium, amiodarone, and defibrillation. The second one, comprehensive diagnostic approach. The patient underwent thorough evaluation, including lab tests, ECG, and echo, which provided essential information on the electrolyte abnormalities, cardiac function, and also the underlying causes of VT. Next, effective management of hypokalemia. The introduction of prednisone and eplerenone to manage mineral corticoid excess was a key strength, which helped in correcting the hypokalemia and minimizing the risk of further arrhythmic events. And lastly, we have resolution of arrhythmic events. The patient's QT interval improved, and no further episodes of polymorphic VT were observed, showing that the treatment regimen effectively managed the underlying cause. As for the weaknesses, we have delayed identification of hypokalemia. While abiraterone-induced hypokalemia is well known, the patient continued to experience persistent potassium deficiency despite significant supplementation, leading to a delay in the correction of the electrolyte imbalance and the development of life-threatening VT. Lack of early glucocorticoid administration. The absence of glucocorticoid, for an example, prednisone, during abiraterone therapy contributed to the mineral corticoid excess and hypokalemia. Ideally, glucocorticoid supplementation should be initiated at the start of abiraterone therapy to prevent such complications. Lastly, we have exacerbation by other medications, such as the use of Clothalidone, a diuretic, further worsened potassium depletion, compounding the patient's hypokalemia and contributing to the arrhythmic event. This medication interaction could have been better monitored. Opportunities include improved monitoring protocols. This case highlights the need for enhanced monitoring of patients on abiraterone therapy, particularly with regard to potassium levels, ACTH, aldosterone, and other electrolytes. Regular monitoring could prevent severe complications like arrhythmias. Next, patient education on medication side effects. Providing patients with clear guidance on the potential side effects of abiraterone, including the risk of hypokalemia, could help in preventing complications and encourage adherence to a comprehensive treatment plan. Lastly, we have development of new treatment strategies because this case presents an opportunity to explore alternative therapies or preventative measures that could reduce the risk of severe electrolyte imbalances in patients receiving abiraterone, such as using alternative drugs that do not interfere with the mineralocorticoid system. Lastly, we have threats that include risk of recurrent arrhythmias. Despite the resolution of the patient's immediate symptoms, there remains a threat of recurrence if the patient experiences further electrolyte imbalances, especially if abiraterone is reintroduced without proper glucocorticoid supplementation. Next is potential for long-term complications. Chronic hypokalemia and the underlying mineralocorticoid excess could have lasting effects on the patient's cardiovascular health, in particular with ongoing risk of arrhythmias and possible long-term cardiac damage. Lastly is interaction with other medication. The potential for drug interaction, in particular between abiraterone and other medications like clothalidone, could pose a further risk to patient safety, emphasizing the need for careful management of polypharmacy in elderly patients. To conclude, this case highlights the importance of addressing electrolyte imbalances caused by medications like abiraterone, especially when used without appropriate glucocorticoid therapy. Severe hypokalemia can lead to serious arrhythmias, including polymorphic ventricular tachycardia, and necessitates careful management of mineralocorticoid effects. Medications such as eplerenone rather than prednisone can be used to mitigate these effects. This study underscores the need for vigilant monitoring of a drug interaction, electrolyte levels, and potential iatrogenic causes of electrolyte disturbances to prevent severe consequences.